So thank you. I'm going to be, as you heard by the introduction, Deborah Mash from the University of Miami. I'm currently professor emerita, and I want to acknowledge a special guest in the audience, Norman Auler, who is a prize-winning writer and journalist, and if you haven't looked him up or looked up his books, please do so online. He's currently written in many things in the field, but his most notable book was called Blitz about drugs in Nazi Germany, and it's not to be missed. So I'm delighted that he decided to join today to listen to me talk about Ibogaine and the identification of the active metabolite. By way of background, I need to give you a declaration of conflict of interest. I am also the CEO and scientific founder of a company called Demorex, which is a clinical stage drug development company advancing molecules for the treatment of addiction. So I'm going to present some of where the company is right now, but also I just want to mention that I've been an NIH-funded investigator for over 30 years, and I've held grants from the National Institute of Neurological Disorders and Stroke, the NIMH, the National Institute on Aging, and more relevant to this talk today is the National Institute on Drug Abuse. I'm also the former founder and director of the University of Miami Brain Endowment Bank, which is one of the largest post-mortem biorepositories of brains donated for research. So I've done a lot of work in molecular genomics and neurochemistry and addiction. And in 2018, at the height of the opioid crisis in America, I felt moved to step out of my academic role and to take over a company that I founded, Demorex, and I went into my company and took over as the CEO to run this company specifically to develop non-addicting medications for the treatment of addiction. And as some of you may know on the Zoom and in the audience, in the United States today, we have the equivalent of about a plane crash or two every week in our country from drug intoxication deaths, largely because of the fentanyl crisis in the United States. And despite the changes and the funding opportunities in the United States to address this epidemic, the numbers are not going down. They're actually continuing to rise. It is indeed thought of as a chemical weapon attack in the United States. So our company has been advancing two molecules. The lead molecule is a psychedelic medicine called Ibogaine, and the active metabolite of Ibogaine, which is, as I will show you, not a hallucinogenic nor Ibogaine. And today, what do we have for the treatment of addiction? And if you want to break the cycle of addiction, you have to get detoxified from your drugs and alcohol. Addiction is a compulsive pattern of use, and people their addiction needs to be interrupted. And indeed, in the beginning of Ibogaine research, they referred to Ibogaine as an addiction interrupter. Well, the approved medicines by the FDA are methadone, which was developed in Germany, which came into the United States, which you can do a methadone taper, so transition someone from heroin or fentanyl, give them lower doses of methadone to get through the acute phase of withdrawal. Lofexidine is the second drug that's approved for this indication. It's an alpha adrenergic agonist, and it's really a next generation clonidine, which is used off-label. So buprenorphine or Sublocade, which is a opioid substitution therapy that's approved for use in the United States, can be used for detoxification, but that's what we have. So these are not effective medications, and in fact, many patients can't get through the cycle of withdrawal. You can go through John Lennon wrote about this, the cold turkey syndrome, the fever, chills, nausea, vomiting, the horrible anxiety. You can get through the acute phase of the withdrawal, but what actually is punishing for the person is that after they get past the 3 to 5 to 7 days of acute withdrawal syndrome, they suffer from a protracted anhedonia. And that is a depressed mood, a dysphoria that lingers for many months. And this is a slide that I like very much from Christopher Evans, who was a pioneer in opioid receptor genetics and pharmacology. And he and his partner, Catherine Cahill, wrote this paper. And it really, I think, underscores what we mean when we talk about this acute state and why breaking the cycle of addiction is so hard. Why is it people can't just break the cycle and stop using drugs? And it's because there is an actual, you can almost think of it as when you get high on an opioid and then you go through immediately it starts to wear off, you start to exhibit some of the symptoms of withdrawal, and then you immediately need to go out and use again. And then you go through withdrawal and you use again and you use again. And so you're constantly chasing dope sickness in the memory of the high. During the protracted withdrawal phase, if stress enters the life, or if you have some kind of trigger for relapse, you get back into your scene, you're back around people, friends of yours that may be using, you immediately remember, if I just have one more hit, one more shot of heroin, one more crack rock, one more vodka martini, one more nicotine cigarette, I'm gonna feel better. And it's that memory of the high and the feeling of feeling better, the euphoria, that triggers the relapse. So we need better medicines. We need drugs that are not only going to deal with the acute phase of the withdrawal, but also can block relapse to use. And that has to be done at the level of the protracted negative affect. So you can think of it, the acquired disease of addiction, as this protracted negative affect. How do you restore functionality in the brain? And then thinking about why people are at risk for becoming addicted, because not everyone does. Obviously, if you don't use drugs or alcohol, you're not going to get addicted. But if you have a risk, if you have low dopamine, if you have trauma in your life, if you have depression, many people have comorbidity for depression and anxiety, and they take a drug like heroin or they take cocaine and they feel better. So there's some normalization. So we know there's genetic risk, but it is in fact an acquired disorder. I heard about Ibogaine because I was working with medical examiners, and in Miami we were on the front end loading of the cocaine epidemic. So before many of you were born, actually, in this room, in the early 90s, Miami was on the front end loading of the cocaine epidemic. So we had so much cocaine, it was Miami Vice, right? There was just drugs everywhere in South Florida. So all of that cocaine that was coming in through the Bahamian corridor, the transshipment from South America through the Bahamian corridor, much of it landed in Miami. And I was working with medical examiners at the time, and I changed my career path to come into the addiction space. And we actually were nicknamed in Science magazine as the Miami Vice metabolite, because when you drink and use cocaine in combination, your liver transesterifies cocaine and alcohol, and you form a metabolite called coca-ethylene, and it's more reinforcing, it's a better high, and it's why people like cocaine and champagne or cocaine and booze. And so we made Science magazine. I was getting national recognition for this work. I was funded by the National Institute on Drug Abuse to do the science. And I started to hear, people started to come up to me and said, Dr. Mash, have you heard of this drug from Africa that can be used to get people off of heroin and hard drugs? And what is it? No, I haven't heard of it. And I was uninterested. I was kind of short with people when they started talking about this. But something happened, they say good things happen in threes, and I heard about it 3 times, and the third time I heard about it was when a man by the name of Howard Lutzoff had contacted me at the University of Miami asking me about the work that we had done on coca-ethylene. And today we know that Ibogaine is a molecule, an indole alkaloid that has over 100 years of ethnobotanical and pharmaceutical use, and I'll give you some of the history behind it. It's supported by extensive case reports and anecdotal observation in patients that are seeking to break their cycle of addiction. And there are testimonials, many of you know, on the internet, thousands of testimonials that the drug brings about benefit. And it's found its way into this emerging renaissance of psychedelic medicine. So it's one of the many molecules now that have entered into clinical trials. This is a brief history of Ibogaine, and I use this slide to kind of give you the perspective on this. We're talking about over 100 years of history of Ibogaine from its religious use. It's used in Africa by the Bwiti and the Fang as part of Afro-Christian religious practice. And they take a high dose of Ibogaine as part of an initiation. I referred to it as kind of a chemical bar mitzvah in a magazine article many, many years ago, because it really lets people get their place in the social network. And we're going to come back and talk about social reward in later slides. But this ethnobotanical use and religious use, this practice has relevance here because it actually brings about a profound recognition of not only your place as an individual, but also as your place in your family and in your societal group. Interesting thing that you can think about. But Ibogaine, along with other molecules, Mother Nature gave us blockbuster drugs, gave us aspirin, right? And Bayer, an important company that, much of the original bioprospecting was around Mother Nature. These were blockbuster drugs before we had modern chemistry, much of which was developed in the advent of pharmaceutical work here in this country. So the two countries that were really doing this type of work, Germany was in the lead, but also France. And Ibogaine makes its way into France, and it was studied, and Professor Goudarel, Robert Goudarel, is thought of as the father of Ibogaine research. He himself an MD and a pharmacist, and he first characterized the structure of Ibogaine. Interesting point, he died the day we put the first dose of Ibogaine into a human patient at the University of Miami. So people had said, oh, the baton has been passed from Dr. Goudarel. I mentioned Howard Lutzoff. Lutzoff is the father of Ibogaine research. He didn't have a scientific background. He wasn't a clinician. He himself was addicted to opiates. And he was was involved in film and part of the whole 60s movement in the United States. And he got his hands on some Ibogaine. Ibogaine didn't make its way much into the United States along with other psychedelics in the 60s. So there were only a small group of people that had access to Ibogaine, but it was part of the underground therapy movement in California. And Leo Zeff is considered the father of this, and they refer to him as the secret chief. So those of you who do a lot of reading in this space, you'll know who Leo Zeff is. Lutzoff gets Ibogaine. He shares the Ibogaine experience with 7 of his friends. He was one of 7, and they discovered they could detoxify themselves from opiates with only a single dose. That idea, that observation, that seminal observation remained dormant until about 20 years later, the late 80s, when he started a company called NDA International, and they had 5 patents. And in the course of doing their 5th patent, Lutzoff reached out to me. And when I got that phone call, I asked him, I said, what is Ibogaine? How does it work? What's the mechanism of action? And I'm still asking that question today. What is the mechanism of action? And what is this? I'm curious. And so I got on an airplane and I came to Amsterdam, and I saw 3 people get treated with Ibogaine with my own eyes. I brought a colleague from the University of Miami with me. I stayed up all night and at the bedside of 3 young men who went through an Ibogaine experience, and I saw the transformation, and that was the end of 1992. And in 1993, when I came back to the University of Miami, I went to my colleagues and collaborators, and I said, this is important. We need to test this, and this needs to be tested in an academic medical center under controlled conditions with patients, and we need to understand something about this molecule. And that's where my journey began. And I went to the FDA in 1993, got the first permission to test the drug, and I went back to them in 1995, and they again gave me permission to test the drug all the way up to psychedelic dose range. So today we believe that the effective dose range for Ibogaine may be between 8 to 10 milligrams per kilogram, and this was the seminal trial that allowed us to go forward. But unfortunately, we could not fund it. There was no funding for this. And when I went up in front of the National Institute on Drug Abuse and asked for the money, they had a public hearing, much like the MAPS Lycos hearing for MDMA approval. The National Institute on Drug Abuse said, well, this is an area of research, we're not sure we want to get into it. So they brought in their experts. They had several day meetings, which I participated in. But at the end of the 2 days, the committee was split, and some people thought Noribogaine was a better molecule to test, but they thought that it wasn't a good bet for taxpayer dollars to advance Ibogaine. We did discover that Ibogaine was converted to an active metabolite, and what I did when I was in Amsterdam, I couldn't do a lot of research there, but I did bring back urine. And as any good shaman knows, active metabolites and drugs that are psychedelics will be found in the urine. And so I brought back urine and we put it on a mass spec, and I told my colleagues who were analytical toxicologists, I was not, I put the box down, I said, find the metabolite, and they did. So I went back to my company that Lutzoff worked with, and I said, can I have that? We're going to put that in the test tube and we're going to learn about that metabolite, and that was the fundamental discovery. And what we were able to demonstrate in this slide, which you can see if you know something about pharmacokinetics and clearance, is that Ibogaine is cleared very quick. So Ibogaine is out of the bloodstream. The half-lives, it takes 5 to 6 half-lives to completely clear the drug. And Ibogaine's out, it's at the level of detection on the analytical assay, but Noribogaine has a very long half-life. So that was the first clue that we had. And if you look at the area under the curve, the AUC gives you an idea about target engagement in the brain, because that's your systemic circulation, right? So I think of it as what's the brain is seeing. The targets in the brain that are being activated by Ibogaine or Noribogaine are much more going to mirror the systemic, the AUC, the area under the curve for systemic exposure rates. So that was the first clue. Now, another historical fact, Ibogaine was marketed in France for almost 20 years under the trade name Lambarine. And Lambarine, why was it marketed? It was marketed in the pharmacies, the little French pharmacies where they could concoct tablets and potions and elixirs and whatnot. But it was 20 years, and people were taking about 4 tablets a day, which would be the equivalent of about 32 mg of Ibogaine. Well, we know that 32 milligrams of Ibogaine will be completely metabolized to Noribogaine. And this is a paper, a publication by Paul Glue, where what he did was he poisoned the conversion of Ibogaine to Noribogaine with a drug called paroxetine, which is an antidepressant, and that will shut down the main enzyme in the liver, which is cytochrome P452D6. What you see there is that when you take a low dose, again, what I've shown you, the Noribogaine, you see much higher, almost 20-fold higher Cmax, but look at the AUC values for Noribogaine compared to Ibogaine. They are for Ibogaine 4 and versus 300. So huge difference with low doses of Ibogaine and the exposure to Ibogaine and Noribogaine. It will become more obvious why this is important. This slide illustrates when you go up to a high dose. Again, Ibogaine is converted through the liver to Noribogaine. So the blue squares there are the Ibogaine pharmacokinetic curve. And Ibogaine has an active phase, an oniric phase, a waking dreamlike phase, different than psilocybin, different than LSD. Patients report it more as a waking dream state or a slideshow or a life review. And it usually starts in about 40 minutes after you take an oral dose of Ibogaine. Some people will report a high-frequency pitch or a sound, and there's somewhat of we think that this has to do with activation of the brainstem and the cerebellum. And then the patients report that the slideshow, the screens come down, and it's this very intense waking dream-like state. But what's interesting is if you look at the time course of that, it correlates with the Cmax, the maximum concentration of Ibogaine in blood, and the duration of it will depend on whether you're a fast, slow, or intermediate metabolizer. But look at the green circles, that's noribogaine. So a day after, when your Ibogaine journey is long since cleared and gone, you're out of the Ibogaine experience, you've got a lot of noribogaine in your blood, which means you have a lot of noribogaine in your brain. And this is the genotyping studies. So everyone in this room, you're either a poor metabolizer, an intermediate metabolizer, fast metabolizer, and some people will have an extra allele and you might be what we call an ultra-rapid metabolizer. So we either have a full gene dosage, 2 functional alleles, 1 functional, non-functional, or dysfunctional. And what we show here, and this is work I did with Scott Obach, who was at Pfizer, headed up the drug metabolism laboratory. This was very cutting-edge research at the time because we were just learning about the genomics of the enzymes in the liver. But working together with Rachel Tyndall at the University of Toronto, and she was an expert at the time on nicotine metabolism. So she was working with alkaloids and doing this type of genotyping work. I went to her and I said, we've got to genotype our patients. So we did that. And what we're showing here is the blue bars would be the fast metabolizers, the ones that have lots of noribogaine in their blood. They had a full gene dose of cytochrome P450-2D6, intermediate green, and the poor metabolizers on the bottom. There's only about 3 to 7% in any population of poor CYP2D6 poor metabolizers. They were the ones who had the longest Ibogaine journey. So in the first 6 patients that we treated with the high dose, we had this profile. We knew that this was the metabolic profile, but also the 10% will go through the lesser cytochromes. CYP3A4, cytochrome P450-3A4, is important for women and how women will metabolize not only Ibogaine, but also other psychedelics. So many of the central nervous system drugs go through this same pathway. When I couldn't fund the research in the United States, even though we had FDA permission, in 1996, after I did everything I could to get the funding, Howard Letzoff couldn't fund the research and he couldn't bring in any money for this, so this was going to stop. And I went to the University of Miami and I spoke to my colleagues, and I had a good reputation, which I'm sure helped me with this. And I had been doing research in the Caribbean in the island of St. Kitts. And the University of Miami allowed me to go off and do psychedelic medicine in the Caribbean. And I had a doctor, a colleague by the name of Frank Irvin, who trained my mentor at Harvard, who himself was on the faculty at McGill University and had been doing research in St. Kitts with primates. He was a psychiatrist. And we set up the first government-approved, above-ground psychedelic clinic anywhere in the world. And we invited patients, because I had been getting a lot of publicity and patients were writing to us begging to participate in the clinical trial. And these were people who, were suffering from addiction to heroin, suffering from addiction to cocaine, many with families and the children suffer, it's a family disease. And so I spoke to some attorneys, got the lawyers assembled and got my colleagues behind me, and we went to St. Kitts. And this is we actually treated over 276 patients. This is the cohort study that was done, and you can see the breakdown. I won't go into this in ethnicity, but this is the largest database, safety and open label efficacy database of Ibogaine that anyone has or has published on in the world to date. Unfortunately, I wish there were more, and hopefully there will be, but this is the largest. And you see in the bottom line there that the years of primary drug use these were people who had failed the standard of care. You know, they had been in and out of detox, in and out of rehab, trying everything they could to get their life back on track, and they couldn't do it. So we had, good motivation and informed consent and working with clinicians and wonderful clinicians. And in 2018, when I, stepped out at the height of the opioid epidemic, I said, it's time to publish these data, so we did. And it was actually Rick Strausman who invited me. He was one of the Frontiers in Pharmacology groups. They had invited people to present, and I know Rick did the seminal work on DMT, and Dr. Strausman reached out to me and said, Deborah, I want you to publish with us in this issue. And I said, okay, Dr. Strausman, we'll do it. And so we did publish that. So the data I'm going to show you come from much of that work using high doses of Ibogaine, allowing the oniric effects. And this gives you an idea of the projected time course of Ibogaine for the treatment of opioid use disorders. And, based on the pharmacokinetics, we know that when you abruptly stop taking your opiate, within 12 to 24 to 48 hours, depending on whether it's fentanyl, which has a little bit more intensity, or methadone, which has a longer half-life, you're going to break withdrawals. But usually it's within about 12 hours where you'll start to see the sickness come on and the panic, the fear that patients go through. And so we were able to demonstrate, at the very beginning, and my colleagues who were skeptics, Dr. Irvin, huge biological psychiatrist and skeptic, walked in, his glasses down on his nose, and he looked at me and he said, well, Deborah, it blocks opioid withdrawals. And we saw it detoxify not only heroin users, but also patients that were maintained on methadone for many, many years. So again, the same thing that I had seen in the Netherlands, but now we're seeing it again. And what was even more interesting was that the patients, when patients go into detox, you go into hospital detox, many of them go right back out the door because they can't get through the detox. Our patients didn't leave. They didn't jump the fence. They didn't go to town. They didn't go out and try to score dope. They stayed with us. So what was amazing, the counselors and the clinicians and the therapists alongside of me got to see this with our own eyes. And what we were able to demonstrate there was this phenomenon of not only the blockade of withdrawals, so whether you're coming off of cocaine and you're going through cocaine withdrawal syndrome, or you're going through an opioid withdrawal syndrome, but in the days after the Ibogaine was this transformation. I feel good. The patients would come up to me and go, Dr. Mash, what's in me today? I feel great. And we just stand back very quietly and observe and say, okay, go to your group meeting, And the patients, many patients who will go into detox and then go into rehab, they skip out of rehab. They won't stay in rehab. Why? Because of that protracted anhedonia. So you can get somebody into rehab and then they leave. And the family spends a bunch of money to get you into rehab and then you leave. You leave against medical advice and your family already paid the money. These people stayed and they worked. And they filled out questionnaires and they participated in the research with us, but they were also getting therapy and treatment. So it was a mood-enhancing effect of the Ibogaine. It blocked craving and the desire to use. It helped them to form a set of alternative expectations, so there was learning. We saw cognition enhancement. We saw it. We tried to measure it. I mean, you could only measure so many things in the Caribbean island setting there, but we looked and we used some neuropsych assessments, and the patients would tell us, they say, Dr. Mash, this feels like mind floss. I mean, this is the words they described. I feel like I have scrubbing bubbles going through my synapses in my brain. I'm like, that's wonderful. You know, what's going to be different this time? Form a plan. You know, what's going to happen when you go home? How are you going to stay clean and sober? Let's think about this. And that was that, you know, again, forming an alternative set of expectations about what was going to be different this time. Remember, these are people who failed detox over and over and over again. So their mindset was, nothing's going to work for me. This is the last road. We used the Hopkins craving questionnaire. Hopkins, the group at Hopkins were did the original work on addiction and really fundamental studies characterizing the phenomenon of craving. Craving is this, you know, we can't get the FDA or regulatory agencies to use craving in a label, a pharmaceutical label. Okay, they don't want craving, but craving, and neuroscientists know craving's real. All right, craving is that when you learn, if you look at conditioned withdrawal, right, or conditioned drug use in an animal model, you can see that animals will learn the reinforcing effects, and then if you put them in the chamber where they've used their drugs, they're going to hit a lever. And my animal behaviorists know this better than me. Patients, the same thing. So we were able to demonstrate using the Hopkins checklist that craving scores plummeted over time, and we measured it out to 30 days where patients were able to be followed, and we were able to demonstrate an enduring effect. The idea of enduring effect of psychedelic is an important phenomenon that we're just learning about. Beck's depression. We use many different mood scales, but I'm showing you the Beck scores here for opioid and cocaine-dependent patients. And many of the patients, opioid-dependent patients, score high on depression. Not a surprise. People self-medicate depression, anxiety, panic, trauma with drugs and alcohol. So these were patients that were about 50% of them would meet clinical criteria, diagnostic criteria for major depressive disorder. Immediate antidepressant effect. And it was lasting out at 30 days. Again, similar to what we are being reported for psilocybin and also for the tryptamines. But what about the Ibogaine journey itself? What about the Ibogaine journey itself? The oniric effect. How important was that? Well, you know, again, this is the late 1990s, and we really did not have good tools to capture this kind of phenomenology. And so I reached out to a colleague of mine in the School of Anthropology at the university. He was the chair, actually, of anthropology at the University of Miami. And when they were working in the HIV/AIDS epidemic, they were using elicitation narratives to try to understand how people used their drugs, why they used their drugs, how they did risky behaviors that got them in trouble with HIV/AIDS. And I said, can we use this type of structured elicitation narratives to content code what the Ibogaine journey means to patients? And I have said this publicly before, and I'll say it again here, I have never taken Ibogaine, so I don't know. I'm a believer as a scientist that I should not take Ibogaine, and I know many in the psychedelic field feel just the opposite, and I respect that wholeheartedly. But for me, I didn't want that bias. I wanted to just look at this with, you know, with a clean headspace, so to speak. So what the patients told us was, they endorsed it, and this was in the narratives that, you know, almost 90+% said that they felt it was useful for their drug experience, that they had been given insight, that they felt that they needed to become abstinent and sober, and you see some of the other top experiences. And the interesting thing about Ibogaine is it is not a drug of abuse. Patients don't really want to repeat the Ibogaine experience. They're not eager to go back and do it again. Some do, some will repeat it. But the patients told us, we said, would you repeat this experience? And they said no. So it's an intense journey for the patient, and it was one that didn't show abuse liability, unlike MDMA and some of the others. But this gave us more ideas about the importance, again, of whether or not the oniric experience of the Ibogaine is important. How fundamental is this to the actual behavioral change? And we know, as neuroscientists, neurons that fire together wire together. So one of the things that when we were working on Ibogaine with the Thai Life Sciences was to develop an immersive VR technology that we could use after the Ibogaine to allow post-Ibogaine integration, where you could use VR and the psychedelic experience to help to maintain that enduring window. You'll hear me talk more about that in a second. And again, these are data that was in my publication from 2018. So stepping back from this and looking at what's the conclusion that we can draw, well, we know that drug addiction is an acquired disease of the brain, right? It's an acquired disease. If you never go out and use drugs, you're not going to get addicted. Even you may have genetic risk. You know, you may have a genetic risk for heart disease, but if you eat well and, you know, don't gain a lot of weight, don't eat a lot of sugar, et cetera, you might not accelerate your heart disease. Same thing with opioid use disorder. So right now, what do we have for patients? We have two things: opioid substitution therapy with methadone or buprenorphine. And that's it. That's it. That's what we give patients. So Ibogaine is different because it may prove to be an effective addiction interrupter because of the psychedelic/oniric effects help to prepare patients for behavioral support and post-opioid detoxification treatment. This is a fundamental question in neuroscience. We do not know the answer. But what they call it in the addiction field is pre-contemplative, contemplative, ready for change. When you walk in the door to rehab, you're thinking about, I need help. You may not know how to get help. You may not see a way out of your addiction. But if you can get to the contemplative phase and start to form a plan of change, of behavioral change, then you're ready to make that transition. And the Ibogaine journey itself may be very important in that as an adjuvant to cognitive behavioral therapy. Put that idea out there. Today, it's estimated that more than 20,000 people have taken Ibogaine in places around the world where it is not regulated. So Ibogaine is being used in the gray zone. Today, patients are getting on airplanes, leaving the United States. Those who can afford to pay will get on an airplane and go take Ibogaine. Publications, I didn't summarize all the other publications that are in the literature. I have several, they're in my review article. You'll see a summary table in my review article on other people's data sets. But across the board, I mean, we know this. Ibogaine blocks withdrawals, reduces cravings. Patients report abstinence for weeks, months, and yes, in fact, some for years. I have patients that are clean and sober today since they took Ibogaine in the 90s. And it is effective for anxiety and depression. What is the problem with Ibogaine? Ibogaine has a dark side. Ibogaine has an off-target effect on the heart, and it causes what is called QT prolongation. QT prolongation is, you can see that in that little green box over there. It's the part of the cardiogram which is from the Q to the end of the T wave. So you see that little T wave over there, and you measure that with a tangent line. And what Ibogaine will do will increase that QT interval. Now, there are other drugs that increase QT interval. Well, I can tell you one, methadone does the same thing. Some of the CNS active drugs do the same thing. There are approved medications that do the same thing. So but the problem with this is that you can have fatalities associated with it if you don't know how to use the drug. We didn't see fatalities in St. Kitts. Okay, and we were the first. I mean, there was no science to guide us, but we were careful. We had medical doctors there. We had people on cardiac cardiac telemetry, watched their cardiac monitor. We made sure we gave, their labs, we did their labs, we screened them. And if we didn't think you were a candidate for Ibogaine, you didn't get it. And we took care of you other ways. We helped you, but you would not be given the dose. We didn't have to send out too many people, but I did make a decision that some people did not get dosed with Ibogaine because we need for safety. But no fatalities, but there have been fatalities because desperate people will do desperate things, and they will go and they will take Ibogaine in settings that are unsafe, with unskilled, unethical people who are willing to sell them Ibogaine and give it to them. And so there have been deaths. And the editors of this journal invited me a few years ago to come in and comment on this as we were starting the clinical trials back up with Ibogaine. And so with Matthias Luz, who was the chief medical officer with us at the time, and myself, we went back and we looked at the published case reports. And across the board, a causality assessment of Ibogaine and the deaths, you can't infer. Proximity is not causality. Proximity is not causality. Just because you took the Ibogaine doesn't mean it's what caused your death. There are drug interactions. You can have potassium, magnesium, calcium levels in your blood are deranged. That's going to put you at risk for a fatal arrhythmia. People die in detox. People don't make it through detox. This is a serious medical condition that needs to be monitored. Ibogaine must be given under full medical monitor by patients, to patients by clinicians who understand the limits of this experimental drug treatment. And I've said that out loud, and I've championed it for years, and I say it everywhere I go, so forgive me, I say it again. But the good news is that people have gotten smart, and they're learned from what we've published, and more people are taking Ibogaine and more people are reporting the beneficial after effects. So I mentioned to you where are we today with the treatment of addiction. Where are we with the treatment of addiction? You have two choices. You go through hospital-based detox, you come out the back end, and maybe you'll be okay, except that they're not okay, because if you look at the bottom box on this graph, okay, abstinence, patients don't make it. So if you do withdrawal intervention, whether you use methadone taper, buprenorphine taper, or an adrenergic, clonidine, lofexidine taper, at 12 months, 88% of the people relapse. So the people in the know, clinicians, do not want to detoxify patients from opioids because they're at risk for relapse and death. So what do? We give them an opioid agonist, maintenance therapy, and you stay on it for the rest of your life. Because again, if you're going to detox from the agonist, you're going to be at risk. And the opioid antagonist, naltrexone, which blocks the high. So some people will go through detox and then they'll take an opioid antagonist, naltrexone, so that if you go out and you slip up and you take, chase the dragon or you bang back some heroin, you're not going to feel the high. And maybe, it's a prolapse and not a full relapse. But the numbers there are bad too, okay? Patients, even as soon as they come off the antagonist therapy, they relapse. So we need something else. And that unmet need for treatment that provides reduced withdrawal, low relapse rates, shorter inpatient stays, and yes, an enduring effect to allow patients to figure out how they can live their life without drugs is what we need. And this is Herb Kleber, and Herb Kleber died a few years ago. Dr. Kleber was very famous. He was the medical advisor to Bill Bennett, which was the drug czar in the United States under the Bushes. And this is the Office of National Drug Control Policy, really famous man. I met Dr. Kleber many, many years ago. And I was at the ACNP meeting, American College of Neuropsychopharmacology, and I was in Hawaii actually at the time, and I was giving my talk about cocaethylene and Yale. He was at Yale then, and they were doing work on cocaethylene following up our lead. And he came up to me and he talked to me, and I said, Dr. Kleber, have you heard about Ibogaine? And he said, Deborah Mash, you're an excellent young faculty member. You've got an excellent career going on. You do not want to get involved in Ibogaine research. And I said, but Dr. Kleber, I said, let me tell you what I saw when I went to Amsterdam and everything. He looked at me and he goes, Deborah, that's Paul on the road to Damascus. And I stepped back and I thought about it. I said, Paul on the road to Damascus? Okay. In this paper in 2008, he published a paper, and this is really important to understand because it frames up where we are today in addiction medicine. Ultimately, the problem of interminable maintenance versus relapse may require learning how to reverse the brain changes associated with addiction. Think about that. Neuroscientists, think about that. And think about that because of a very famous, brilliant MD PhD by the name of Dolan. And hopefully she's going to come and present for you as well at your forum that you host. And Dr. Dolan has looked at psychedelics in animal models, and she has demonstrated that she is really like an expert in this field of social reward and critical learning periods. And she believes, her data and her colleagues believe, that they have demonstrated that psychedelics turn on metaplasticity in the brain. Think about Kleber's quote. And this slide, if you haven't read this paper, it's a homework assignment, you must read this paper. It's really superb. So what she is demonstrating here is she's looked at, and I'm going to make it cliff notes now, ketamine, MDMA, psilocybin, LSD, and then Ibogaine. Ibogaine, that green line. Look at that green line. Okay? That's the window of neuroplasticity involving, we still don't know all the molecular targets and downstream cascades that are involved in this, all right? But it's opening this critical learning period. Can you unlearn? Can you break the cycle of addiction? Can you remodel the brain? Can you restore function? And she believes that these are master keys. That's her word. Psychedelics are the long sought after master keys for unlocking multiple critical periods across the brain, a property that can be harnessed for therapeutic benefit. She thinks the enduring effects mirror the oniric state. Okay, but I say no, Dr. Dolan, and I love her research. I'm like a huge fan of hers. If you look at the bottom graph is the half-life. So she thinks that the trip equates the duration of the psychedelic experience, or in the case of Ibogaine, the oniric experience, or in the case of ketamine, the dissociative state is the key factor. But with Ibogaine, I showed you, Ibogaine is cleared from the blood, and we know that Ibogaine is the oniric effect. So does nor-Ibogaine contribute to this? Okay, and this is what I'm going to come into the conclusion on for you. But before I do this, I want to share with you another important publication that has just come out in Nature Medicine, top-tier journal, by Nolan Williams and his team at Stanford, and this is the magnesium Ibogaine therapy in special ops veterans. So these are patients that were seen at Stanford, they had neuroimaging done, and full psychological battery, depression scores, anxiety, etc. And they went down to Mexico, they took Ibogaine, and then they came back to the United States and they were evaluated. He has not published yet the neuroimaging data. I can't wait till he does. but this is the MYSTIC protocol. By the way, magnesium was used in St. Kitts in my trial. Magnesium stabilizes the heart. So he demonstrates, again, what we were able to demonstrate, and not only does he see, these were special ops veterans in Operation Enduring Freedom, Operation Iraqi Freedom. These were people who had multiple deployments, came back to the United States very sick, and many of them were using alcohol and or drugs, huge trauma, horrible, PTSD and cognitive problems that showed remarkable efficacy endpoints at 30 days after the Ibogaine treatment. And the drug was safe. So right now in the United States, again, the drugs are always, we have my colleague sitting here, drugs are political. Drug treatment in any country, you get right away into politics, right? And Sublocade, buprenorphine has been what our government in the United States is full in. This is a blockbuster drug. This year it's going to be around $820 million, and they're on track to go up over $1 billion. They control, and the more that our government puts money into this treatment, the more patients go on this, and this is a lifetime of opioid substitution therapy. If Ibogaine were to advance through regulatory approval, the drug would be a method of care treatment which transitions patients to abstinence, giving them back their life as a whole functioning person in their family and in their society. Opioid maintenance is not a cure. So this is where we are, and it's unclear whether Ibogaine will advance through regulatory approval. But at the same time this is going on, and you know this for other psychedelic molecules, there is a major push now for next generation molecules. So these potential substances which will be used in clinical settings under very controlled conditions, companies are now competing to take the hallucinogenic experience and retain the therapeutic benefits of the molecular engagement. And Demorex is one of those companies. So I stand here in front of you working on this idea. But there are also two competing companies that I want to familiarize you with, and that's Delex, who's also working on noribogaine style derivatives, and Gilgamesh, which just signed a mega deal with a company called AbbVie to develop. And they have different pharmacologic properties, but the bottom line here is that we know that this window, if we believe, and we believe that the psychedelic, what we're learning from the renaissance of psychedelic medicine is that, these are very potent neuroplastogens or psychoplastogens. And Dave Olson and his group at Delex, he coined the term psychoplastogen. And he's an amazing chemist, as is Dalibor Samis, and I'll talk to you about them in a minute. But this is the idea, that we open this window of neuroplasticity and it bring about therapeutic benefit. But do we need the trip to reach the destination? Or is the psychedelic experience simply a biomarker of this window of neuroplasticity, this critical learning period that Goldolin has described in animal models? We don't know the answer. We do not know the answer. This is a fundamental scientific question in the psychedelic field, to be answered by very smart young neuroscientists, okay, in the laboratory with animal experiments and also in the human clinic. Noribogaine is non-hallucinogenic, can be developed as a daily dose pharmaceutical treatment, and Demorex is looking to do this for alcohol and opioid use disorders. And the work of others, not me, the work of the Delix team led by Dr. Olson and also Dalibor Samas at Gilgamesh, feel that this plasticity is mediated probably by the metabolite of ibogaine. This demonstrates that if you give noribogaine in animal models, that animals will stop taking cocaine and opioids, they won't take nicotine, they'll stop drinking alcohol. It's it doesn't look like other psychedelic molecules. So all the animal data stacks up strong in favor of noribogaine, and this is work demonstrating that noribogaine dose-dependently blocks alcohol intake in rodent models of alcohol use disorder. So Demorex is on the way with noribogaine, a new chemical entity that targets multiple brain circles to regulate alcohol craving, improve mood, and treat protracted withdrawal symptoms that trigger relapse. Now, obviously, I like to say alcohol is a poor man's opiate, so these data will be seminal for also supporting the use and development for an opioid relapse prevention indication. But alcohol is a much bigger market share, and because you have to get the money to do the research, and the government's not going to pay for it, so you have to go out there and get people to fund your research. So that's where Demorex is going. And I want to end on this idea of polypharmacology. How does this, if it is the metabolite, and if it is acting to reset a neurochemical loop in the brain, how is it doing it? Well, exciting for me, because I was one of the first to characterize noribogaine in the test tube. Dr. Dalibor Samas and his group at Gilgamesh have demonstrated using their new compound series, which is on the right, and you see it's oxonoribogaine, and there's noribogaine on the left. We discovered in my academic lab, it's a serotonin reuptake inhibitor. It's a partial kappa agonist, and it also acts on the alpha-3 beta-4 neuronal nicotinic receptor. Why is this interesting? I was fascinated by it because the addiction circuitry, the dopamine circuit, all drugs of abuse elevate the neurotransmitter dopamine. You can't block dopamine and treat addiction. NIDA spent a lot of money doing that, trying to come up with dopamine-sparing cocaine antagonism. Forget it, all of that money went down the drain. But what this does is it's targeting around the circuit. It's actually a circuit level effect. And that makes sense because CNS drugs that are effective drugs have to act on multiple targets. It also acts on glial-derived neurotrophic factor. And you know about BDNF, brain-derived neurotrophic factor, important with serotonergic psychedelics. This is the dopamine one. This is what pumps up your dopamine in the brain. This is what changes dopamine cycling in the brain. It's a U-shaped curve. You can't have too much GDNF. You'll become hyperdopaminergic. That would make you crazy, right? You'd be at risk for serious mental illness. Too little deficiency of GDNF would be what? What's the opposite? What do you get with low dopamine? Anybody? Parkinson's disease, right? So in the Parkinson field, they have tried to put exogenous GDNF in brain. You can't do it. But here's a way to regulate. Think about this. Noribogaine and low-dose tablets will regulate the GDNF expression in the brain. So there may be other indications for noribogaine and the next generation molecules that are being developed, which are based on the ibogaine scaffold. Very exciting work. And I've explained this. I'm going to jump across this slide to where our company is right now. Our company is in an active phase of growth to bring these clinical trials online as quickly as possible. I've been working on this for so long that we just want to get this into the clinic, get it tested, demonstrate does it work or not, and do we have an alternative for patients who are desperate for a way to break their cycle of addiction. And hopefully we will be able to demonstrate that. And I'm very excited to be here because this week, after our FDA hearing in December, Type B meeting with our colleagues at the FDA, and the FDA has always been wonderful to work with, in my experience. I know everybody else, some people don't feel that way, but in my experience, they've been very good to work with. And they gave us incredible guidance, and we started our Noribogaine repeat dose study in the UK and London. And right now we have 11 patients that are taking repeat doses of Noribogaine, and we'll be ready from these data to pick a target dose, and hopefully in 2025 we'll be in the clinic and we'll be working with patients. And I'm very grateful, and thank you for coming out to hear me today.